Thank you, Tityal sir. And I think Himanshu's covered it so well. I'll try to stick to just a few things that I thought might be useful. And I would like to congratulate uh, KLB Instruments for organizing such a wonderful webinar. They've been a big supporter for Pentacam for so many years, and especially Rohit for making it so interesting for all of us. So I hope my screen is now
Yeah,
visible.
it's there, it's there.
Thank you, sir. So I think when I came to know that Himanshu speaking just before me, and I know that he does such a great job, I said, I'll have to just stick to a few things. So we all understand that when we do a refractive surgery workup, we do measure on many devices, as Dr. Namrata also mentioned that, and Dr. Tityal sir and everybody else, that don't rely on just one device or just one map. And I really go crazy when people come with that one printout of a Pentacam saying that, sir, this is my report. It's like seeing a ultrasound B scan report of one printout and trying to comment on that. I always end up telling them that I'll have to repeat it. Sometimes we do it free of cost because patient has just got it done 2 days before somewhere else and come up with a print. So I think that point was well taken home. So the Pentacam, in addition to many other devices that we use for refractive surgery workups, can give you a lot of interesting stuff here. And of course, we've gone through all of them. When it comes to phakic lenses, what Nimanshu tried to tell was that sizing is the thing that actually interests us the most. Of the vault and the sizing, these are the two things which would interest us most when we are looking at all these devices. And when we are doing a preoperative planning, amongst all the other things, I think the wide to wide, the pachymetry, and the AC depth, these come into the domain of instruments like the Pentacam and the others like the OpScan, the OCT, and the UBM, and so many others. And then we can also do the STS. So there's been, ever since I started doing ICLs, maybe 15, 16 years back, we've had, gone back and forth and back and forth for sulcus to sulcus, and then to the white to white, and then the other things. And after everything, I think we are still back to the white to white, and it still seems to work the best. But then how do you measure the white to white and the AC depth predictably? Pentacam, I think, as Himanshu showed, does a great job. I have a few other things to share. Of course, we all know what is the ideal vault, and we are all aiming for the ideal vault, and then we do have the range in which it can still work. So all that can be judged better using the Pentacam has been very useful. And in fact, the day a Pentacam Pro breaks down, Divakar gets a call from me. I cannot even work for a day without the Pentacam in my refractive surgery workup of patients. So let's start with few of the things that it might immediately show when I look at a patient first, and I've already decided that I'm not doing a LASIK or a smile for the patient or even a PRK, and I'm starting to look for ICL. First important thing I purposely put this here is that make sure that you're not reading the external AC depth. By default, sometimes the Pentacam maps tend to give you the external depth unless you go into the settings and set it right. You may be mistaken. Sometimes it'll show you a 3.3 or a 3.4 and you'll be excited. And actually the patient's AC depth might be just 2.8 after subtracting the cornea. So please make sure that this shows internal, and that can be done from the settings. After that, there are other things which you can measure. So I like to also look at the AC depth profile. As Himanshu just mentioned, it may be, one thing in the middle, especially in keratoconus patients or other patients. And I like to, from the drop menu, you can pick up the AC depth profile and look how much it is in the periphery, whether the central depth is the area where it is the most, and any irregularities in the AC depth. You can again, of course, look at the iris configuration, and I won't go into the details there again. Now, another important thing which comes out from the first map when you open the map is something that you can see over here, and I've zoomed it out for you. You can look at the chamber volume, you can look at the angle of the iris, you can look at the pupil diameter, the AC depth. Again, you have to make sure that it's not the external and it's the internal depth that you're measuring. And then here, which was something which has been added recently, was the horizontal white to white, which is automated on the Pentacam now. It wasn't so a few years back. And this again is very, very useful. So I made a short video clip to show you how, I measure it in two ways, and Himanshu showed a beautiful way, which I do as well. And then I also use the iris image option. So you can, from this drop menu here, you can choose the iris image. Now, typically the iris image will show you many things, and you have to switch off a few of them. You can switch off the central topography in which it shows up in the Pentacam. I don't like to use that. You can switch off the automatic limbus marker as well. I like to see it without. I'll just show you how it works. And you can use the calipers which are somewhere here to switch on, and then you can take these manual measurements yourself like this. So it'll tell you whether this is, for example, 11.54. Then you can repeat a couple of measurements. I remove the limbus marks, and then I try to use the white to white. These images are very, very good quality, and these measurements are very, very accurate. We've done a study over the last 2-3 years of about 123 eyes comparing manual measurements, Lenstar measurements, and Pentacam. And frankly, I trust the manual measurements. And then now today, Pentacam and the manual measurements have shown almost complete accuracy, but not so with a few other devices like the iTrace and the Lenstar that we use. Now, this is the other way to look at it. So, on the holiday map, holiday report, you can again have a look there. I'll just pause it here for a moment. And if you look here again, the horizontal white to white is here. So it's in a couple of places, but I always like to cross-check it myself manually. One of the two ways, as Himanshu showed you on that shine plug image, or also on the iris image, you can do it either way that you like and prefer. Now coming to what literature has shown us. So this is a study which showed compared ASOCT for measurement compared with the Pentacam and the UBM. And they were trying to do the measurements pre and post-op for the AC depth, the central ICL measurement, and the vault measurements. And the result, this is how it worked. The ICL depth, the full AC depth, the vault, and the three things were measured on the three devices. And it came up with very good agreement between the three. But the conclusion said that the ASOCT demonstrated significantly higher value, while Pentacam showed a significantly lower value than the UBM, probably because UBM is done in the lying down position, but they showed very good consistency. So typically the three things have shown excellent consistency, but they cannot be interchanged with each other. They have to be used on their own. So as Himanshu said, and I agree completely, you can measure on 5 devices and they're all pretty good, but rely only on one of them to actually do your decisions and don't keep interchanging them. So one or two more studies and then we'll call it a day for this talk today. Another study which compared the discrepancy in the horizontal white to white measurements using calipers versus the Pentacam, and it compared the accuracy and found a strong correlation between both methods regarding all parameters. Again, you can't interchange them completely, but whatever you're going with is what you should be using. But there is very good consistency between the consistency. And then again, another study which compared interchangeability for two parameters, the AC depth and the white to white between the ILMaster, the Pentacam, and a few other devices, and we'll restrict ourselves to the ILMaster, the Pentacam, and the OpScan. So it concluded that you can interchange the Pentacam HR, the OpScan 2, and the ILMaster 500 readings. Now, I don't like to interchange them, but they are pretty predictable. And for the AC depth, let's just see, this was the comparison. For the AC depth, you can see here that they're pretty good. There's very little difference. But again, when in doubt for an AC depth, please do it with 3 devices. I like to do it with the optical biometer, with the Pentacam, and I try to also do it with the A-scan and then take a decision. Similarly, on the white to white, you can see that there's pretty good consistency between the caliper at 11.77 plus minus 0.3 and the Pentacam at 11.75 plus minus, and the others I typically try to ignore unless I really need it. Now, theoretical interest, you can use anybody, if he still does the Pentacam, there is a PIOL software on the Pentacam, and that can be used for iris claw lenses. And with that, we do follow up our patients. As Himanshu said, for 15 years, we were following up on the Pentacam, and then last 5-6 years, we do it on the OCT because that tends to give you a little better readings. But if you don't have a good OCT for the ID segment, you can still use the Pentacam and use it very effectively for measuring vaults. We keep measuring vaults on ICL patients on post-ops. They tend to go down over the years, and you have to keep a watch on them. And with that, I'd like to stop here. Thank you. It's invaluable for us. So with that, I